Hattiesburg, Mississippi. We're here at ASDIN 2025 in Grapevine, Texas, and we've got another great treat for you. Dahlia?
Good morning. I'm Dalia Dawood from Riverside, California, and today we have the pleasure of interviewing and the honor of interviewing the legend, Dr. John Ross. He is the founder of Dialysis Access Institute, and he will be joining us today and answering some of our questions about how this is all started.
Well, concerning ASDIN, how it started,
yes.
A long time ago, I guess it was in the late 90s, maybe 98, 99, something like that. I met Gerald Bethard at the Mary Center in Memphis, Tennessee. We were teaching nephrologists and surgeons how to do interventional procedures and surgical procedures. I had no idea who Gerald Bethard was. Had no idea. Of course, he had no idea who I was, so it didn't make any difference. So I got to meet Stephen Ash and Jack Work at that time, and so a few of the others that became legendary in ASDIN, and it was the idea, is it worthy of an organization? Should we have a society? So it was concluded, yes. So we're sitting in the Peabody Hotel there. That's where the ducks come walking by. I'm not sure if anybody had a drink or not. I'm not sure about that, but it was okay if they did. So the original name that was thought of was going to be Society of Interventional Nephrology, SIN. We thought it was all going to be quite appropriate name, but we found out there was a Society of Italian Nephrologists, so we had to, another name came up. So needless to say, I was there from the beginning. I had been training nephrologists a couple of years before that, and of course, as a surgeon, I came under a lot of criticism for that, as you might well imagine, but I didn't care. So as time goes on, we continued with the training program under ASDIN, which was absolute joy. In fact, the practice was so large, sometimes we would have two, and one time we even had three there at a time. And I constructed the training program back then like an old-fashioned general surgery training program where you had a senior at different levels, because you really don't know what you know until you try to teach somebody else. Yes. Then you could say, well, that didn't sound quite right, did it?
That's a very good point.
So with ASDIN, we kept the training program going, still do it to this day. A lot of my friends are in the ASDIN program, and of course we learn things here, but equally important is the socialization that we have. That's pretty important. That's how I got involved with ASDIN.
So I know you mentioned in the morning that you initially was not what we call a renal surgeon, like surgeon who specialized in vascular access.
That's right.
How did you make that decision to become more involved with vascular access to the extent that you become the founder of the Dialysis Access Institute? Well,
it's a very interesting story. It was not designed that I was going to be a dialysis access surgeon. Didn't know anything about it. So I went to a small town in South Carolina, but I was the only surgeon for 4 counties. So the volume of surgery was just tremendous. But back in those days, general surgeons did the vascular surgery. In fact, we did anything that we thought we could do at that point in time. So early on in the career of going there, within 2 months, a nephrologist called me from a neighboring town. He said, can you do an AV fistula? Of course, the only answer would be, of course I can. I had no idea. So as time went on, nephrologists talked to each other, and when they needed an access done, and they said, you've got this crazy guy down in South Carolina, he will do them the next day. So we were getting patients from all over South Carolina, and we actually started doing elective procedures on Saturday and Sunday because the volume was so great. And as time went on, we're doing this huge volume, and there was nowhere to get percutaneously trained. There was no such thing. In fact, the first angioplasty balloons in access were like 81, 82, 83, something like that. So I learned all about that, but the first percutaneous declot I did was probably 10 years after I did the first declot as an open surgical procedure. So as time goes on, the practice becomes more and more and more focused in dialysis access, less than chest surgery, less than other vascular surgery. So with the training program and the large volume of patients we had, there was almost no such thing as a clinical trial going on in dialysis access unless we were involved in it because we had the volume to do it. Then as time went on, up up until 2011 or so, these little small hospitals were going to close. And we had this huge volume of dialysis patients that we need to take care of. Where are we going to take care of the patients? So there was an adjacent community, a much bigger hospital, about 20 miles away. They wanted me to bring the whole practice up there. So we already had, we were doing about 3,200 cases a year of access then, something like that. And I said, okay, I will bring the entire practice, but you've got to build this building for me. And the building, 16,000 square feet, 6 operating rooms, every operating room with its own C-arm, the ability to do live cases and send them anywhere. In other words, by prescription, I told them what the Dialysis Access Institute had to be, and they said, okay. So they built it. It's probably, from a building standpoint, one of the premier places, and maybe in the world, that does this kind of thing. There are other places that do really good work, but not like dedicated with a building built for it, and it's under what's called a hospital outpatient department. So now what we do everything that can be done in access, we pretty much do in that building. We have 2 surgeons, we have an interventional radiologist, and we have 3 interventional nephrologists. So what happens is that we do this coordinated thing, like we talked about collaboration in this arena today. There is an intense collaboration that we have. The interventional radiologist may be doing a case and he knows that a surgeon needs to take a look at this, or we might do the same thing. We need a radiologist to kind of take a look. We need another opinion. So that's how the Dialysis Access Institute got to be what it is. And as of recent date, we have been incorporated with the University of the Medical University of South Carolina, and it's all working out very well.
Wonderful.
If you build it, they'll come. And that's really the ideal, have all those people under one roof. Right?
It is. And so the patients that we see, we don't schedule office visits. There are no offices. What we do, if you need a fistula, we have 2 ultrasound technicians. We have everything in the building to do everything. And even on certain occasions, if I need a cardiology consult, I can get it while the patient is in the building.
That's great.
Maybe get an echocardiogram if we need it. So the idea was to be totally inclusive in one place, and that has worked out very, very, very well. But to get anything to work in a hospital environment, or maybe any environment, you've got to have the administrators that want to help you get it done, because the logistics involved, the paperwork or computer work nowadays, is so involved. If we don't have that, it's very difficult, isn't it?
So you have trained so many interventional nephrologists, and I'm quite sure radiologists, and maybe vascular surgeon. There is some debate about how much training, how many procedures somebody has, because you could get certified after you do a certain amount of procedure. But in your opinion, how many procedures or how long training for somebody to becoming an expert or a profession in that field?
Yeah, Dolly, that's a very, very good question and observation. And in my opinion, you can't do it by numbers. I have seen people come to me as nephrologists that really, they thought an 035 wire was 35 inches long. They knew nothing. They knew nothing. But they were gifted. And within 5 to 7 days, they're doing declots all by themselves.
Wow.
I've seen this. I've seen this many times. And so those people, with the volume that we have, within 6 weeks, they've done a couple hundred cases. And what would happen at the end of that time, we have didactic lectures that go on, and some people just absorb. Some people are smart. Others of us are not quite as smart, but some people are just smart. I've seen others that they don't have the talent and maybe should not be doing it, and it would take a huge amount of time. We all have seen that. So I can't put it on numbers of cases, and I can't put it on time. We also train the nephrologist to do surgery.
Oh, yes.
Which is a huge amount of time that's going to require multiple visits, taking time away from practices. And again, we've got people that are doing basilic vein transpositions, all the big operations that were nephrologists as we speak right now. Other people thought that the jump from nephrology to interventional nephrology was this big. The jump from interventional nephrology to surgery is this big. And so sometimes that to give the appropriate time for that, you're looking at a year commitment.
Year commitment. So to summarize, it's really for the intervention nephrology or procedure-wise, like the endo part of it is depend on talent of the interventionist. For surgery, if you're going to train them to do surgery, that's almost 1 year commitment to be able. Brian?
So you trained a lot of people, including one of my partners.
Including one of your partners, that's right.
So what's the hardest thing to teach people?
The mistake I've made many times is thinking something is intuitively obvious to somebody and it's not. And I've learned that no matter what kind of background people are coming in with, is that I tell them initially, I assume you know nothing. And everybody seems to be really good with that. So when we get nephrologists in, or surgeons in, sometimes cardiologists would come in, nephrologists still, I demand of them that not only do they do the percutaneous procedures, they've got to scrub on the surgery. I'm actually trying to make a point, is that to get them saturated in the system, and they will find out it really lights them up, that this is really a lot of fun. I think I want to do this. We've actually had so many of them, when they're done with the program, they go out and do interventional nephrology and don't do any other nephrology at all. And I think it's just a matter of the kind of person that's coming in, an assessment of them. But if they've got the energy, they don't need an IQ of 165. I need energy, because most of these things, with the commitment of wanting to do the right thing and knowing what the right thing is, and give them an algorithm. Because a lot of things that you've never seen, if you know the basic algorithm, you can figure it out on the spot. Sure. You've done that, haven't you?
Yep.
Absolutely.
So you have trained for so many years, and you have seen several different generations from, you said, from the early 90s. What is the difference between new trainees' attitude over the time? Like, do you see different, like this was brought up yesterday, that generation is different. Work-life balance becomes something that everybody's looking for. Where in my generation, everybody just work, and just want to provide the highest level of care. So did you see or observe change in how new trainee see this profession, or like their commitment is different? What's your comment on that? What's your take on that?
Here, that's been asked in the surgical community a lot.
Yes.
In training programs in vascular and general surgery, you know, we used to say it would be awful to be on call every other night because you miss half the cases. The idea was that you wanted to do more. You want to do more and more and more. It was not looking at the clock. You wanted to do more cases. So there's a spectrum, maybe in a bell-shaped curve of some kind, of the people that come in. I still see people with that burning fire to do this. But if we displaced this 20, 25 years ago almost, there are more people that would come in that would have the fire to do it than we see now, I think, percentage-wise, although you still have people that have the fire, if that makes any sense at all. But I think the expectations of a previous generation, this is opinion-based now, was that the work-life balance, it was, they equated a lot of work with a little bit of life. And I'm not saying wrong or right, I'm just saying it's different. Then now we have, life is getting bigger and the work is coming down. Is that what you mean?
Yes,
and
that's what I mean.
That is definitely there.
Does this new idea of work become less and life become bigger in our profession, which impact patient life? Do you think it did impact patient quality, like patient quality, like taking care of patient?
Oh, I absolutely think so, and this is strictly opinion-based, because it's typically now, and I'm not saying going back in time when I was doing this all the time, if a patient had a clot needed to be declotted on Saturday or Sunday, they got declotted on Saturday or Sunday, because everyone understood that the patient needed to have dialysis soon. So the commitment was when we got 3 declots to do, Saturday morning, okay, I'll see y'all at 8 o'clock, we'll get them all done, and then if another one comes in, we would do that. I'm not saying that's really good all the time, but that was the philosophy. And the philosophy of the practice of medicine, I've seen this transition over a long time, and it is quite a bit different than the 80s, the 90s, and certainly now.
It's just, and it's also opinion, and we can talk to Brian about that. I believe when you sign up to be a doctor, when you sign up for medicine, you choose to be in medicine, you know that that's come with calls and commitment of providing the highest level of care and delaying care because you want to focus on the life part. Maybe you shouldn't go to that profession. It's just being a soldier in the front line. When you go to the army, you know
things that are hard take passion and effort, right?
But I don't think, again, we're all on a bell-shaped curve, no matter. We used to be on the left side.
Yes.
Hopefully we moved over in the middle and maybe function on the right side a little bit now. And I think that if I can make the analogy, the bell-shaped curve has shifted somewhat, where the expectations of the people that trained us, or the model of medicine that we looked at, that model, they used to call them role models kind of thing, if you like, the cliche. That role model, it depends on who your role model is. If your role model needs to come in at 9 o'clock and get through at 4, that's your role model. That was not the role model 30 years ago.
Yes.
And so the expectations of new people now to fit in an old program, they don't understand that.
Got it. Now let's switch a little bit gear to talk about ASDIN. You've been attending the meeting for so many years.
Never missed one.
I know that. So how did you see the meeting progressed over the years? What your observation?
I think the meeting, it's a very good question because it has evolved. Generally speaking, at the very beginning, even interventional work by anybody was not very sophisticated. Then if you think over the next 25 years, 26 years or so, devices came along, new things we could do, new skill sets we could do. And so ASDIN's job was to keep up with the skill sets. It was to keep up with the devices. And it had to gain this proverbial respect. Because remember, when it started, there was little to no respect there at all. And then, because it was so different, you had people that were in private practice, and you had someone to sign up for a course somewhere to go without any kind of accreditation. Although we had some baseline things that needed to be done in numbers, compared to a residency program in nephrology or a residency program in surgery or a residency program in anything. So we were claiming that this is a specialty unto itself. So what has happened, I think that the nephrologists now, interventional nephrologists, I actually think they respect themselves as far as being able to take care with wires and sometimes operate as good as people that have gone through full residency programs and other things. That has changed. And now ASDIN has the respect of all these programs out there. You're out, the surgeons know it. I know this, the surgeons know it. Even as mentioned today, the radiologists know this. So that has been the progression.
Awesome. Brian?
So this year is about collaboration, and you have been such a wonderful friend to ASDIN as a surgeon. How do we get more surgeons involved?
Oh, it's going to happen by default. Surgeons want to, and you'll go to places that you think you shouldn't go. You would go to vascular surgeons and general surgeons. Let me explain. One of the tenets now to become a general surgeon, when you go through a fellowship program, you must do dialysis access. That came about a couple of years ago. So I'll tell you a short story. So one of my good friends called me up and he says, John, you need to apply for what's called the Master Surgeon Educator. What is that? It's by the College of Surgeons. I said, I'm not into that kind of thing. He said, no, you need to do this. So you submit all the articles, you submit what you've done, and it was accepted into that. So I go up to Chicago to get this little award. And one of the guys that ran the program up there came up to me and he says, Dr. Ross, you know what you've done? I said, what? You have, because all that master surgeon educator came from what? Dialysis access. He says, we have recognized now dialysis access as a specialty. So, where am I taking this? I think to have a formal program that would make available, like meetings like this and training programs like this, to places that you would not normally go, like vascular surgery departments. Because you look at the vascular surgeons around the country, as of a few years ago, I was told, the number of access procedures they did was 2.6.
Very minimal. Yep.
And then percutaneous, there's nothing. And the problem we see when vascular surgeons come for training, they're applying AA, arterial surgery, try to apply those tenets and principles to AV. Mm-hmm. They don't work.
Yes.
They don't work. Mm-hmm. So to go in that direction, I think you're going to see ASDIN has the possibility to grow, because there's really nowhere else to go that specializes in interventional nephrology. Yeah. You've got the whole thing.
Mm-hmm. Actually, Dr. Bethard just suggested that notion. He said that with the involvement of interventional radiologist and surgeon, he might really want to change the subspecialty from interventional nephrology to dialysis access care. So to include all of the stakeholder, interventional radiology, interventional nephrology, and surgery in that.
I did not hear that, but that's a great idea, because see, I don't call what we do vascular access, I call it dialysis access. Mm-hmm. There's a nuance there, like the Dialysis Access Institute. I wanted that in there to open the concept up that you can actively go after other specialities that actually need to know how to do this work. I think it's pretty important.
Yes. So if we would like you to, if we ask you to give a statement to our audience today, which members of ASDIN, either the attendees today or online, what would you like to say?
I think the thing to say is that ASDIN started a long time ago, and it has created the specialty of interventional nephrology. It created it, it started it, it did it, it grew it. I can't think of another model that has ever done that in medicine. That's big. You did it.
Thank you. We did it with the help and the support of a surgeon who believe in vascular access care and how this has impacted patients like you, Dr. Ross. It's absolute great pleasure and honor that we have interviewed you today, and we hope that you enjoy the rest of the program. And again, we cannot get enough of interviewing you, so we might have a second part tomorrow.
That's right.
Brian?
Yes, we really enjoyed talking with you. Always insightful.
Well, was it fun?
It's always fun.
Absolutely.
That's right. It's supposed to be fun.
Brian, thanks a lot.
Good to talk to you.
No, yeah,
Thank
always.
you. Thank you.